Hello everyone, this talk is going to be on arrhythmias. My name is Hannah Orme, I'm one of the CTFs at SWBH, and these slides are from Dr. Ali and he's given me permission to use these today. So when we're talking about arrhythmias, we're talking about either an abnormal rhythm or an abnormal rate. And we can categorise these down further into bradycardias or slow heart rates, tachycardias or fast heart rates, and then within tachycardias we can further differentiate narrow complex and broad complex. So we're going to start with bradycardias first of all, and we'll talk about some of the causes. And I like to remember this as divisions. So drugs, particularly beta blockers and calcium channel blockers, ischemia, so myocardial infarctions, vagal hypertonia, infection, sick sinus syndrome, infiltration. O I remember as low, so low thyroid, low potassium and low temperature. Neurological, so raised intracranial pressure, septal defects and surgery or catheterization of the heart. So we can classify bradycardia into sinus or normal rhythms. First degree heart block, where the PR interval is greater than 200. Second degree heart block, and we can differentiate between Mobitz type 1 and Mobitz type 2, and complete heart block. So in terms of treating bradycardias, if the heart rate is above 40 and the patient has no symptoms, then actually treatment might not be necessary. It might be normal and physiological for that patient. If the heart rate is less than 40 or they have symptoms, then we do need to treat it urgently. So obviously we need to correct any underlying causes. Medically, we can give atropine, 0.5 to 1.2 grams IV, and then we can consider external pacing of the heart to increase that heart rate. And then longer term, we can think about permanent pacing, so insertion of a pacemaker. Okay, so we'll talk about narrow complex tachycardias now. So it's a tachycardia, so it's got to have a rate above 100, and it's a narrow complex, so the QRS complex is got to be less than 120. So some important differentials would be sinus tachycardia, atrial, which could be AF, atrial flutter or atrial tachycardia, and AV nodal re-entry tachycardia and AV re-entry tachycardia, which we'll cover in more detail in your ECG interpretation talk. So in terms of managing the narrow complex tachycardia, as with any A2E assessment, we will consider if oxygen is needed and establish IV access. It's then important to decide, is the rhythm regular or not? So if it is, then we can give vagal manoeuvres or adenosine, 6 milligrams. It's really important to have a continuous ECG trace so that we can assess any abnormalities, if it's worsening, etc. If the rhythm isn't regular, then we're going to treat it as AF. If the rhythm is regular and there are some adverse signs, then we need to correct this as soon as possible. So we need to sedate the patient and provide synchronized cardioversion or amiodarone to try and get this rhythm back to normal quickly. If not, then we can give digoxin, amiodarone, verapamil or atenolol to try and correct the abnormal rhythm, or rate rather. Okay, so now broad complex tachycardia. So our important differentials will be VT, Torsades de Poix and SVT with bundle branch block. In terms of the causes, I like to remember it as I'm quick. So infarction, myocarditis, long QT syndrome, valvular abnormalities, iatrogenic causes, cardiomyopathy, and K is potassium, and then I remember the other electrolytes and oxygen. So potassium, magnesium, and low oxygen. In terms of managing broad complex, the first question is going to be, is there a pulse? If there is, then we're going to start oxygen and IV access and check for any adverse signs. If there's no pulse, then we treat this as an arrest and we begin CPR. So if they have got adverse signs, then we again need to sedate them and synchronize cardiovert them, because we need to get that heart rate back to normal and reverse any adverse signs. If they don't have any adverse signs, then we've got a little bit more time to correct things. So we can correct the electrolytes and then reassess the rhythm. If it's regular, then we can give amiodarone or lignocaine. And if it's irregular, then we're going to treat it as AF with bundle branch block. And if at any point this fails or the patient becomes unstable, we go back to synchronized cardioversion. Okay, so now we're going to talk about atrial fibrillation. So some common causes would be ischemic heart disease, thyrotoxicosis, hypertension and infection. And some other important ones to consider would be alcohol, post-op and hypokalemia. So in terms of signs and symptoms, often it's completely asymptomatic and picked up incidentally. However, some patients may complain of some chest pain or palpitations, maybe some shortness of breath and faintness, particularly if it's a fast AF. In terms of the signs, so you'll feel an irregular pulse, and there may be a pulse deficit or some signs of left ventricular failure. So in terms of our investigations, you might see a narrow complex on ECG. It can be fast or slow, and it will be typically irregular, and by definition there'll be no P waves because we haven't got that atrial contraction or the organised atrial contraction. In terms of your blood tests, you're going to do all your kind of routine standard blood tests, but the key ones to focus on would be your full blood count and your U's&E's. Your thyroid function tests, because we know that high thyroid levels can cause atrial fibrillation, and then troponin, because we know ischemia can lead to atrial fibrillation as well. Imaging, it's important to get an echocardiogram to show if there are any structural abnormalities of the heart. And now management. So if it's an acute onset, so it's been less than 48 hours since the onset, if the patient is hemodynamically unstable, then we go to emergency cardioversion. If they're stable, then we can start low molecular weight heparin. It's important to control the ventricular rate. As we've said, AF can be fast or slow, so this might not be necessary. But if it is a fast AF, then we do need to control that rate with flecainide or amiodarone. For this acute onset, there's no need for long-term anticoagulant because actually they're at a very low risk of developing a thrombus and kind of having a stroke. So paroxysmal AF is self-limiting. It typically lasts for less than 7 days. In terms of managing the patient, we do need to anticoagulate them, so we use the TRADS-VASc score to consider the risks of anticoagulation versus the risks of not anticoagulating. Many of these patients are managed in a pill-in-pocket approach, so the patient takes their medication as and when they feel they need it to improve their AF. So just quickly, going over the TRADS-VASc score, it's very important that you kind of understand the risk factors for anticoagulation and not anticoagulating. So typically with AF, for paroxysmal AF, if the score is 0, then we give 300 milligrams and then 750 milligrams of aspirin daily. If it's 1 or more, then we need to consider warfarin or a DOAC. So persistent AF is AF that lasts for more than 7 days, and we need to consider rhythm control and rate control. So for rhythm control, we check for structural abnormalities with an echocardiogram, and then we consider electrical or pharmacological cardioversion. For rate control, we typically use a beta blocker or a calcium channel blocker. We can add in digoxin if necessary, and we can consider amiodarone if the patient's not improving on those measures alone. For any atrial flutter, we manage as for AF, so we consider amiodarone. And that concludes the lecture part of this topic. We'll be covering the single best answer questions in your tutorial. Thank you.